Good morning, everyone. My name is Borislav A.Alexiev. I'm the Director of Surgical Pathology at Northwestern Memorial Hospital, and it's an honor to be with you. The topic of my talk is the solitary fibrous tumor of the thoracic cavity, extrathoracic sites and central nervous system, clinical pathologic features, and risk stratification models. Solitary fibrous tumor is a mesenchymal neoplasm of fibroblastic type encompassing a histological spectrum with two main morphological variants. SFT phenotype characterized by patternless architecture of short fascicular pattern with alternating hypocellular and hypocellular areas and thick bands of collagen, and the HPC or hemangiopericytoma phenotype characterized by diffuse high cellularity and limited intervening stroma. Tumor cells are spindle shaped or oval and with blank nuclei and scanty eosinophilic cytoplasm, thin-walled branching vessels, called also HPC-like or staghorn vessels, are feature shared by both phenotypes. The discovery of shared recurrent NAP2 STAT6 gene arrangement in both SFT and HPC has confirmed the identical nature of these neoplasms. The fusion, which exhibits variable breakpoints, drives the STAT6 nuclear expression by immunohistochemistry, which is a routine diagnostic marker in our department. More than 40 fusion variants have been identified. The most frequent, the NAP2 exon 6, STAT6 exon 16, 17, and 18, occurring most frequently in SFTs in the meninges, soft tissues, and head and neck, and the NAP2 exon 4, STAT6 exon 2, 3, occurring most frequently in soft tissues in the pleura and lung. There's no difference between the histology, SFT, and the fusion gene variants. Solitary fibrous tumors may occur in any anatomical site, including thoracic and abdominal cavities, superficial and deep soft tissues, visceral organs, bone, and the central nervous system. The two images which I present now, there's as you can see, a large SFT involving the pleural cavity, and then another one in the abdominal cavity. Macroscopically, SFTs are well circumscribed masses with typically measure between 5 and 10 centimeter. The cut surface is nodular, tend to red-brown, and occasionally shows hemorrhage, necrosis mixed with change, and cystic degeneration. On tissue section, tumors with the so-called SFT phenotype demonstrate a patternless architecture, hypo and hypocellular areas, collagenous background, and the gapping staghorn-like vessels which are typical for this entity. The diagnosis is usually confirmed by immunohistochemistry, and in this case you can see the strong STAT6 expression in the nuclei of the tumor cells. The HPC phenotype is much more hypocellular with very little intervening stroma, same type in branching staghorn vessels, and like the other phenotype, strong expression of the STAT6 confirms the diagnosis. As far as the biologic behavior is concerned, except cases which have overt sarcomatous transformation and tend to behave like conventional high-grade sarcoma, the behavior of SFT has been difficult to predict, despite histopathological criteria for malignancy proposed by England and colleagues in 1989. It is well established that morphologically benign tumor may occasionally metastasize, and conversely, many tumors classified as malignant based on histologic findings alone have indolent clinical course. The current 2016 WHO CNS grading scheme incorporates the phenotype SFT or HPC and mitotic rate to stratify tumors in two categories or groups: grade 1 benign and grade 2 and 3 malignant. As far as the soft tissue is concerned, thoracic and extrathoracic tumors are classified by mitotic rate alone into SFT and malignant SFT according to the latest WHO classification of soft tissue tumors. The existing soft tissue sarcoma grading systems like the FNCLCC and the NCI have shown to be poorly applicable for SFTs, and also the soft tissue sarcoma staging system incorporated in the latest HJCC staging manual, the 8th edition, have not been validated for use in predicting the biologic behavior in SFT. The development of risk models for the prediction of metastasis risk in SFT has resulted in improved prognostication of the traditional benign malignant characteristic. And in this, I would like to draw your attention to the studies performed at MD Anderson by D'Amico and her colleagues. They reported a novel risk stratification model for SFT incorporating patient age, tumor size, and mitotic activity to predict risk of metastasis, which is very similar to the one used for GIST, for the gastrointestinal stromal tumors. In the D'Amico models, the 3 and 4 variable models, there are 3 or 4 risk factors: patient age, mitosis, tumor size, and then the 4 variable model, also tumor necrosis included. Patient age is scored as 0 if the patient is 55 years younger, and 1 if the patient is 55 years and older. The mitotic activity is scored as 0 if there is less than 1 mitotic figure per 10 high power fields, and 1 if there are 1 to 3 mitotic figures per 10 high power fields, and 2 if we have 4 or more mitosis. The tumor size is scored as 0 if the tumor is less than 5 centimeter, 1 if the tumor is between 5 and 10 centimeter, and 2 if the tumor is 10 but less than 15 centimeter, and 3 if the tumor is larger than 15 centimeter. The total scores are summed, and the scores of 0 to 2 is considered low risk, 3 to 4 is intermediate risk, and 5 to 6 is high risk in the 3 variable risk model. For the 4 variable risk model, presence of tumor necrosis is scored as 0 if the necrosis is less than 10% of the tumor parenchyma, or 1 if the tumor necrosis is more than 10%, and added to the risk score generated by summation of age, mitotic race, and size score. However, neither of these risk models for prediction of metastatic risk have been validated for CNS, SFT, and HPCs. So at Northwestern Memorial Hospital, our team sought to validate the D'Amico's risk stratification model in an independent cohort on SFTs from a different patient population, and if possible, establish a unified risk assessment approach for CNS and non-CNS neoplasm. We located 72 patients in our register, 39 females and 33 males, with a female to male ratio of 1.2 to 1, median age 56 years for females and 57 years for males. Tumor location: 17 of the tumors occurred in the CNS, 28 in the thoracic cavity, and 27 in the extrathoracic side. The total follow-up ranged from 1 to 240 months, with a median of 48.5 months. Statistical analysis was performed according to the current guidelines. Metastasis-free survival is defined as time in months from diagnosis until either distant mets or death. Recurrence-free survival was defined at time in months from diagnosis until either local recurrence, distant metastasis, or death. Both metastasis-free survival and recurrence-free survival were compared with the 3 and 4 variable risk models by D'Amico and colleagues, as well as by mitotic rate, and separately for CNS and non-CNS. The CNS cases also were analyzed using the WHO grade, and the survival analysis that was performed by the Kaplan-Meier method, and the survival across groups compared using the long rank test using the appropriate software. As far as local recurrence is concerned, 48% of the cases in the CNS presented with local recurrence, 14% of the tumors in the thoracic cavities presented with local recurrence, and 7% of the tumors at extrathoracic site presented with local recurrence. Distant mets occurred in 18% of the CNS primaries, 1 de novo and 2 after local recurrence. In 7% of the thoracic primaries, all de novo, and in 19% of the tumors in the extrathoracic site, 3 de novo and 2 after local recurrence. Metastasis occurred in bone, lung, liver, kidney, and pancreas, and for death, 472 patients occurred, 6%. In the total follow-up with primary tumor, 2 of which showed dead differentiation, thyroid sarcoma transformation, located in the retroperitoneum, head and neck, meninges, and abdomen, respectively. The microphotographs demonstrate metastasis of SFTs in the bone, classic SFT phenotype, with pleomorphic large tumor cells and increased mitotic activity. In cases with dead differentiation, the tumor presented with features which are usually not seen in the conventional SFT and HPC, lacking hemangioperitocytoma blood vessels, but the diagnosis was confirmed by the STAT6 immunohistochemistry as well as by molecular studies, which demonstrated the STAT6 and NAP2 rearrangements. So in non-CNS cases, both the 3 and 4 variable risk models were significantly associated with metastasis-free and recurrence-free survivals. All events in the non-CNS cases were observed among those with scores 2 and 3, either in the 3 variable or 4 variable risk models for both metastasis-free and recurrence-free survivals. For non-CNS cases with score 2 and 3 in the 3 variable risk model, patient had a 5-year metastasis-free survival of 80% and a 5-year recurrence-free survival of 60%. For non-CNS cases with score 2 and 3 in the 4 variable risk model, they had a 5-year metastasis-free survival of 72%, so lower, and a 5-year recurrence-free survival of 41%. In all non-CNS cases, all events for distant metastasis or death were observed in cases with high mitotic rate as defined by the WHO mode of 4 mitosis per 10 higher power field, corresponding to a 5-year metastasis-free survival of 69%. In CNS cases, however, no significant difference were seen either metastasis-free or recurrence-free survival based on the 3 or 4 variable risk models, the WHO grade or mitotic rate, although the power was limited by the lower number of cases. For the combined outcome of distant metastasis or death, all 3 events in the CNS were observed among cases that were both grade 2 or 3, with other words, meet criteria for malignancy, at a high mitotic rate, corresponding to a 5-year metastasis-free survival of 83% and 82% respectively. As far as the mitotic rate for CNS and non-CNS cases is concerned, in non-CNS cases, all events for distant metastasis or death were observed in cases with a high mitotic rate, more than 4 mitosis per 10 higher power field, corresponding to a 5-year metastasis-free survival of 69%. Similarly, 10 of 11 events for recurrence or death were seen in high mitotic rate groups, corresponding to a 5-year recurrence-free survival of 47% among cases with a high mitotic rate and 97% among cases with low mitotic activity. In CNS cases, no difference was seen with either metastasis-free or recurrence-free survival based on either the 3 or 4 variable risk model, WHO grade or mitotic rate, although as I said earlier, the power was limited due to the lower number of cases. As far as the local recurrence and the risk for distant metastasis at 5 years, the local recurrence rate for CNS cases was 57%, and the risk for distant metastasis 13%. For tumors arising in the thoracic cavity, with other words, in the lung and the pleura, the risk for local recurrence was 24%, and the risk for distant mets only 5%. And for extrathoracic site, the risk for local recurrence was 13%, and the risk for distant mets 14%. Differences across sites, CNS, thoracic, and extrathoracic, were not statistically significant for either metastasis-free or recurrence-free survival. So in conclusion, for tumors outside the CNS, the study at Western Memorial Hospital showed that the 3 and 4 variable risk stratification models proposed by our colleagues in Houston were associated with a recurrence-free survival, in addition to the previously known association with distant metastasis. For tumors inside the CNS, our study showed that neither risk model is significantly associated with clinical behavior, and that the WHO grade is still likely the best available prognostic tool, though none of the differences were statistically significant. So the lack of significant differences between CNS and non-CNS cases can likely be explained by the younger median age 47 years versus 61 years, and small and medium tumor size 3.5 versus 5.6 centimeter, downgrading the risk stratification score in CNS compared to non-CNS primaries. And in conclusion, the existing 3 and 4 variable risk stratification models of SFT are not associated with clinical behavior for tumors arising in the CNS, but are associated with local recurrence in addition to distant metastasis outside the CNS. If you have any questions, I'll be very happy to